Thank you. All right. So I just want to first say I have no conflicts. I have no, any ownership in any products or anything out there. I don't get paid that much. So, all right. So this is actually a picture I got from one of, actually I see Kate in the front row here, one of her former residents who got bit by a tick and was like, "Hey, do you want a picture of this?" I'm like, "Absolutely." So, this is an embedded adult deer tick. We see a lot of this time of year. These adults, as the prior presenters have already kind of pointed out, this is kind of the time of the year for the adults to start to become more active. Lyme disease, as you guys all know, is a variety of different syndromes, and there's the kind of the classic erythema migrans rashes that you can see on the left-hand side. The one on the top left is a little bit more faint, but very clear and had serologic positivity, as well as the one on the bottom left, which looks more like cellulitis. I think the one key point I want to take for diagnosing this versus other etiologies. If you see something like this on a patient and they don't have pain, right? Don't call it cellulitis, right? Because that's probably the most common thing that I see happen is people see something like this expanding red rash. It's not tender. They're not having any pain with it. And they get, Keflex and other medications before they actually get their doxycycline. So that's probably the biggest take home from the rash perspective. There are neurologic complications. There's the Lyme carditis that we worry about. And then there's also the late disseminated manifestations that you can see over on the right side. That's actually my niece's knee from several years ago. She probably picked up a tick bite in the spring from a nymph, had a several-day course of kind of flu-like illness, stayed home from school, did fine the rest of the summer, and then this is what happened in September. And at that point, all of her bands on her immunoblot were positive. Lyme rashes can present in a variety of different ways. So the kind of the classic bullseye rash is kind of the one up on the top left there. This is actually a puzzling case because this was back when I was in the military. This was a guy in Afghanistan with this rash. And, this is the power of taking a good history. So we found out that he's actually from Massachusetts, had been home on R&R for in between his tour, has basically spent 2 weeks camping with his family in rural Massachusetts and Connecticut, and clearly got a Lyme infected bite. But you can see the other rashes here, they all look a little different, and they can look different. I don't have any pictures on here, but dark-skinned individuals also can get these rashes. It's just much harder to pick up, and it's something to be really cognizant of. And then I think the other thing too is if you see a rash like the one on the bottom right, where you have multiple rashes, just remember multiple rashes is a possibility, right? Erythema migrans can disseminate through the skin. And if you have somebody who has tick exposures in an endemic area like we're in, that's something that you need to have on your differential. Now, as far as the diagnostics are concerned, it's already been brought up. They're not great. Right. So we have indirect tests that are primarily what we use. And for anybody in the audience that doesn't know the difference between direct and indirect, indirect tests are basically, we are measuring your patient's antibody levels to the infection. Whereas a direct test would be something like PCR or culture, something where you're looking for the organism in some form. And unfortunately with Lyme, we just don't have great direct tests because there's not a lot of spirochete, available in the blood. Generally not a ton of it in any other body fluids other than maybe synovium. And maybe you could do a biopsy of a skin rash and send that off for PCR. But again, if you've got a rash that's potentially concerning for Lyme disease in an endemic area, why biopsy the patient? Just put them on some doxycycline. The standard two-tier test has been around for decades. It's something that we've been using for so long that it's kind of embedded. It's got this two-step approach where you have the ELISA, the screening ELISA, and then the confirmatory immunoblot. There are some false positives as well as false negatives that you'll definitely see with this test, especially earlier on in the course of disease. You can see on this slide here, this actually looks at the standard two-tier test along with the C6 assay over on the right. And you can see earlier in the acute and the convalescent phase of erythema migrans, which is the early localized infection, sensitivity is not great. It's, 30% early on, only about 50, 60% after that. So you're going to miss 40% of those cases. So you want to make sure that you're treating people who have a possible rash up front. Now, once you get longer into the course of illness, generally speaking, the sensitivity is going to go up across the board with these serologic tests. The neurologic, the cardiac manifestations, almost every single patient I've ever seen has had a positive two-tier test or a C6 assay, or the new modified two-tier test, which I'll talk about. Same thing with the Lyme arthritis. I think that's probably the most immunogenic, and that's where you're going to see most of these tests coming back positive. There are some caveats though, right? So if you have somebody who's immunocompromised, if they have steroids, if there's anything that's affecting their ability to mount an immune response, you have to take that with a grain of salt. And that's where the nuance comes from, the not so clear component of Lyme testing and treatment. These tests, as I had mentioned, do have some false positives. Things like influenza, MS, some of the autoimmune diseases, syphilis, chronic fatigue syndrome. These are all things that potentially could trigger a low level positivity in these standard two-tier tests as well. We heard somebody bring up PCR earlier. This is one of those direct tests. This is generally not recommended. I see this ordered frequently from providers kind of out in the world. I actually accidentally ordered it the other day on a patient, and I kicked myself about it. But this is not something that's really going to be all that beneficial, right? You just don't have a lot of spirochetes in the blood. And I've only seen one PCR positive blood test in my entire career. And it was about a month, about 6 months ago. You can use it in synovial fluid, although I believe the IDSA guidelines are actually kind of steering away from that a little bit, and then potentially just treating based on serologic testing and response to therapy. I generally tell my residents and medical students not to order CSF PCR. I kind of basically describe it as taking $300 and lighting it on fire, because it's a waste of money. I've seen maybe 2 cases of PCR positivity on the CSF. It's very easy to just say, all right, I've got somebody who has Lyme exposures. They've got Lyme serologic testing that's positive. They have a lymphocytic pleocytosis on their CSF. I'm just treating that as Lyme disease until proven otherwise. I mentioned the skin biopsy. Again, not something that is routinely done, generally speaking. This is a little of an antiquated slide. This is the C6 assay. This is something that Oxford Immunotech had put out. And I was a big fan of this. I was using this pretty much extensively in my Lyme disease clinic because it has some benefits that I'll get into. It's fairly comparable to the two-tier testing in terms of sensitivity and specificity based on each of the different stages. You might have some earlier IgG antibodies with this. The sensitivity is potentially something that could be affected with other genotypes. And, one of the things that have been documented in the literature is Borrelia miyamotoi can have some cross reactivity with that. And I've definitely seen that in clinical practice. But the thing on the bottom here, somebody asked, well, how do you know if somebody has an old infection versus a new infection? And the answer is you can't really tell, but this test can help a little bit and help guide where you're going. And this is how I use these tests. So I'm going to go through a whole slew of these, and they're going to get boring after a while, but you're going to get the point. So this is a dog study that actually looked at dogs on the left that were not treated versus dogs on the right that were treated for their Lyme disease. And you can see they really had no change in their C6 assay on the left-hand side, whereas by about 6 to 12 months, their assays actually dropped down pretty significantly. If you use a standard two-tier test and immunoblot, those IgG bands are probably not going to go away for years, if at all. I've seen people who had been diagnosed with Lyme disease a decade earlier, they still have IgG positivity. It's not something that I would rely on at all. So I tell people, if you've had a standard two-tier test at some point, tell your doctor never to order it again, because it's just going to cause a lot of confusion and sow doubt into the patient's mind. This is another study looking at dogs. So you can tell that the dotted line is dogs that were treated for their Lyme, and the solid lines that stayed elevated were not treated, very clear cut. You saw, again, by about 30 weeks after infection, they almost had undetectable antibodies to the C6 assay. These are non-human primates. On the left-hand side were the C6 test. On the right-hand side are standard ELISA. These are all patients or primates, non-human primates that were treated. And again, you can see that their assays persisted on the standard ELISA, whereas the C6 drops down nicely. This is actually a human study. This was looking at patients in a azithromycin study. And again, by about 26 weeks, most people have a drop in their C6, pretty much down to either undetectable levels or nearly undetectable levels. There's that one individual that persisted, as you can see there. This was an azithromycin study, which if you're familiar with azithromycin, I consider it like a fourth-tier drug for treatment of Lyme disease because of the relapse rates. This patient did relapse. They didn't really have any kind of full completed treatment. And after the data is not here, but after they treated this patient again, that assay actually showed that they resolved their C6 antibodies as well. And again, more data looking at people with single erythema migrans versus multiple erythema migrans. So this is primarily for the C6 assays. Unfortunately, Oxford Immunotech doesn't really offer it anymore, which was a big kick in the butt for me in terms of how I was managing my patients. So what they have done is the FDA has approved this modified two-tier test by Zeus Biomedical, and this is basically doing away with the immunoblots and doing the standard ELISA versus this VLSE peptide C10 ELISA, which that VLSE1 component of that assay is very similar to the C6. And I've looked and seen very similar response to my patients after treatment, where I will actually trend that assay, and you'll actually see it drop much like the C6 assay. So if you wanted to know if somebody's having a resolving treatment, resolving therapy, or resolving to therapy after their Lyme, I like to get one of these tests at baseline when you have the diagnosis and you're treating, and then maybe follow it up 6 to 8 weeks later and really focus on their clinical symptoms, right? You know, you're not treating a number, you're treating their symptoms, but generally speaking, about 85% of my patients, they're going to have a drop in those antibodies over the course of their treatment. And usually about 6 to 12 months after that, they're either undetectable or they're around the level of the borderline level of detection. I also like this, the modified two-tier test compared to the standard two-tier test because there seems to be slightly higher sensitivity in the earlier stages. You can see 63 versus 78%. So there's some benefit to using it from that standpoint. It may still be worthwhile just to do the standard test up front if you're thinking about screening for people either way, because it can be difficult to get this test done correctly. I find that if I order it through Upstate, I get it done correctly every single time. But if I send somebody to the LabCorp, one of the other commercial labs, it's really 50-50 in terms of whether or not they're going to do it right, or they're going to send you a Lyme PCR, which you just kind of scream at your computer about. All right. Again, you're going to pick up potentially more early infections with this test compared to the standard two-tier test. And generally speaking, it's something that is probably going to become more available as we move forward. Upstate may be bringing this test in-house. Right now, it's a send out to Salt Lake City, and it takes about 2 weeks for it to come back. So for me, it's useful because a lot of these patients coming in to see me are already Lyme diagnosed and they've been treated, and I'm trying to figure out, all right, do I need to treat more? Do I not? These tests are not perfect. All right. And this is a study that kind of highlights that even despite treatment and despite the patient kind of going through all the right things at follow-up, they still do have some people will still have an elevated titer, and it's hard to determine what to do with those patients. Those are probably my most complicated ones, where you have these titers dropping down, but they really don't have any symptoms that are getting better. They kind of plateau, and then their antibodies just kind of stay elevated. Those are the ones where I start scratching my head a little bit, and I have to determine, all right, do I need to retreat? Do I need to try something intravenous? Or do I need to think about other things that could potentially be causing a false elevation? So a lot of shortcomings to the diagnostics. They're insensitive in the early phases. The sensitivity may be lower if you're looking at different genotypes that are out there. These, again, are indirect tests. And you can have false positives, as I mentioned. There's a lot of other tests out there that are not FDA approved, but are kind of waived and are somewhat more boutique tests. I'm not a fan of these. I do look at them and I review them and I take them with a grain of salt. But there are some questions. Why didn't you go and do the full FDA approval? Why didn't you go through that process? There was this interesting study in 2014 that looked at a university reference lab, commercial lab, and then 2 of these specialty labs that are out there. I'm not going to name names because I don't want anybody to sue me, but they took 40 healthy people, right? People who had no evidence or history of Lyme exposure whatsoever, just to see what the false positive rates were. And for the university lab, you see on the bottom there, it was about, I don't know where my little mouse is, about 12.5%. The commercial lab didn't really have the numbers. The specialty lab number 2 is about 2.5%. One of the other big specialty labs that are used out there had almost a 60% false positive rate. So if I'm going to send somebody out and have them spend $900 out of pocket, because most of the insurance companies aren't reimbursing for this test, I want it to be the best possible test out there. I don't want it to be something where I could take a quarter, flip it up in the air and say, yep, you have Lyme or you don't, right? So that's where I kind of run into some issues with some of the specialty labs. There are a lot of people who are misdiagnosed and are told because of some of these tests that are out there that they have Lyme disease when maybe they don't. There's definitely cases that are in the literature as well as in my own clinical practice where people had lymphoma or other forms of malignancy causing many of their symptoms because of perineoplastic syndromes that are often overlooked. People can get line infections. We had one patient who came to our clinic and told this harrowing story of having a PICC line in for 18 months and developing a yeast infection in her bloodstream that nearly prompted them to have to do a valve replacement because they thought she had endocarditis. And basically her provider said, well, not my problem. And then I've actually run into this myself. I had a patient who I was on the fence as to whether or not I needed to treat further. I gave this patient a 4 to 6 week course of IV ceftriaxone for kind of residual symptoms and Lyme arthritis symptoms, and they developed C. diff. My patient did not die of their C. diff, but this is always a concern because we do see quite a bit of this in practice. And then there's other things like DRESS syndrome and different types of severe reactions and immune responses that you can have. So, I tell people all the time, if I'm going to treat you with an antibiotic, you got to remember that these are essentially mild chemotherapeutics, right? These are going to affect your bone marrow. They're going to affect your liver. They're going to affect your kidney function. You want to make sure that they're aware of the risks before you're actually using some of these meds. Now, the chronic symptoms are the things that a lot of you guys probably struggle with because there's not a ton of data. And that's, I think, the part that we struggle with. These patients generally don't feel well. They have brain fog. They have word finding issues. A lot of them have chronic joint pain, joint swelling. Muscle aches are a big one. Headaches are a huge one. They're almost always fatigued. Many of them have kind of chronic pain and paresthesias or neurologic pain syndromes of some sort. And these can be really difficult patients to treat because there's not clear-cut data to say what the best options are. So I'm going to go through a little bit of what I've seen and what I've tried to do in my practice. So first thing I want to talk a little bit about is antibiotic refractory Lyme arthritis or post-infectious Lyme arthritis. This is a process that is after the Lyme infection, after treatment, they have persistent joint pain, all right? These patients have synovial cell hyperplasia in their joints. There's vascular proliferation and T-cell infiltration. There are different strains that may be more likely to cause this. And these are generally patients that have been PCR'd and cultured from the synovial fluid repeatedly, and they've all come back negative. There is also some understanding that there may be different HLA subtypes that can potentially, in the patient, that could potentially predispose people. There's been some studies done at the SUNY Binghamton that talked about looking at people who had a predisposition genetically to different autoimmune disorders and having a higher likelihood of joint pains afterwards. And there's also this thought that these peptidoglycans that are excreted by the actual spirochete may potentially cause a pro-inflammatory response inside the joint. This is actually an interesting mouse model where they purified this peptidoglycan, injected it into the mouse joint compared to a placebo. And you can see on the right, there's significant swelling 1 day post-injection. So this kind of goes into the idea of, all right, well, maybe antibiotics aren't going to do it, right? And that's actually been my experience. I could give people like, weeks and weeks of antibiotics, but their joint pains don't often get better. And what I find is that some of the rheumatologic medications that are out there are a little bit more beneficial. And then on top of all that, and I've seen this probably more so in the past 18 months than really ever in my career, there is definitely some data out there, and this is coming from Alan Steer's rheumatology clinic out in Massachusetts, looking at the triggering mechanism of autoimmune disorders in people who may be predisposed. All right. So I've had one patient who developed a vasculitis, 85-year-old woman who developed vasculitis who had no business developing that at that age. This is something that she should have had in her 30s to 40s. The only thing that was different is a year prior to presentation, she had Lyme. It was clear-cut Lyme. She had a tick bite. She had serologic testing and she responded to antibiotics. And then a year later, she went into renal failure, had pulmonary nodules, and had biopsy-proven vasculitis. I've had psoriatic arthritis, as I've mentioned. I've had other people develop things like rheumatoid or other connective tissue diseases. And this is something that some of the rheumatologists have definitely seen in practice as well. And I'll get into that a little bit. I'm not going to go too much into the neurologic manifestations because Dr. Fallon's going to be talking about that tomorrow, I believe, in terms of the neuropsych. But this is probably the most difficult group of patients for me to treat because there's not a lot of data to help kind of direct, and I haven't seen anything definitively that helps. I've tried long courses of IV antibiotics. I've tried things like combination antibiotics for these patients with daptomycin, ceftriaxone, and doxycycline because of some limited data coming out of Johns Hopkins, but it's very hit or miss. I had one person said that they felt great and then they never came back and they were doing wonderful. And most of my patients don't really have a response. But these patients suffer from headaches, paresthesias, fogginess, this kind of cognitive disturbance. I send a lot of my patients for neuropsychiatric testing to see if there's some kind of occupational therapy that can be beneficial, but I've not seen a silver bullet for these patients. And I think this is where the prevention of getting infected in the first place and the education we try to get of our patients is really the biggest part of what we need to do, because if we can prevent them from developing this stage of disease, that's really the key. Central pain syndromes are definitely some things that I've seen. These, again, are difficult and something that if you have a pain management group that specializes in central pain syndromes, that could be a benefit. And then there is potentially persistent infection. It's very rare in my experience, but I have seen patients who come in and for whatever reason, they either don't metabolize the oral antibiotics as well, or maybe they didn't absorb them because they were, taking their doxycycline with a big glass of milk for 4 weeks straight. I don't know. But I have had patients where, they come to see me after being on doxy multiple rounds, and then I give them cefuroxime and their symptoms melt away. So it's just something to keep in the back of your mind, especially if you have somebody who comes in and, their modified 2-tier test titers are still really high. It's something that could potentially be beneficial and help them. People who go on to have some of these chronic symptoms, generally the older the patient, the more likely that's going to happen. And if you have multiple erythema migraine rash to begin with versus solitary, there may be a slight increase as well, just based on the pathogen burden. So what is there to do? I'm going to focus a little bit more on the Lyme arthritis component. These are the standard tests, the standard treatments that are out there. I believe that Wes Kufel, one of our pharmacists, is going to go into this in a little bit more detail tomorrow, as well as the doxycycline prevention dose that we can potentially give and where to go with that. And these are straight out of the IDSA guidelines. I want to reiterate, they are guidelines. It is not, it is not the Bible when it comes to infectious disease and Lyme disease. but this is something that should be your starting off point. I will fully admit that if I see somebody with erythema migrans in my clinic, I probably don't give them 14 days of doxy. I probably do 3 weeks, because I've seen too many people come to see me after getting a 10 to 14 day course of doxycycline, and they still have symptoms afterwards. All right, but that's my own preference. That's something that everybody can deal with on their own. Azithromycin is on here. I see a lot of treatment failures in people who are forced to take that medication because of tetracycline and beta-lactam allergies. This would be a scenario where, you might want to try to desensitize the person if possible. And then, these are the different durations for the different manifestations. So this is all in the IDSA guidelines for whatever it's worth. You can take a peek at those. As far as the other stuff that's out there, this is the only thing I'm going to touch on with neurologic Lyme would be, potentially using gabapentin. Some of my patients have some benefit. Many of them don't. I have other patients who seem to have better luck with Lyrica, but I don't know if there's any actual data to support that. And then there's the DMARDs, the disease-modifying anti-rheumatologic drugs such as methotrexate, infliximab, or hydroxychloroquine. These have been used for antibiotic refractory Lyme arthritis and are actually in the IDSI guidelines now, where they actually recommend somebody has Lyme arthritis that's persisting, that is not responding to antibiotics. It's something that you should consider getting rheumatology involved. So again, the general approach that I take with somebody who comes in with Lyme arthritis, if they've been on doxycycline and they never really got fully better, I might give them another round of doxy. All right. If that doesn't work, then I might give them amoxicillin for a 3 to 4 week course, or maybe ceftriaxone. And then I might consider going to the IV ceftriaxone. If I've gone all the way through that gamut and they've gotten multiple rounds of oral antibiotics and they've gotten a 4 week course or sometimes a 6 week course of IV ceftriaxone, and they still have symptoms, that's when I start to consider, all right, maybe we're dealing with that kind of more inflammatory process that's going on. Meloxicam works well for many of these patients to kind of take the edge off. I generally personally steer away from the corticosteroids because there's always that doubt in my head that there's potentially some spirochetes still floating around. And there's definitely some data to indicate that maybe there's some issues with relapse with steroid use. Physical therapy is on there. I think that's a reasonable thing to do. The thing I've had the most luck with personally is using hydroxychloroquine. I usually start people on 200 milligrams once a day and do that for about a week, and then advance them to 200 milligrams twice a day after that. And most of my patients have some decrease in their joint pains by about the 2 to 3 month period. And the nice thing about this isn't like rheumatoid arthritis where you're going to put these patients on hydroxychloroquine for the rest of their life. This is something where you're trying to get them through this inflammatory process. Most of the data that I've seen, and from my experience, is about 1 year to 2 years, you can probably start to wean them off these medications. If they don't respond to hydroxychloroquine, I have methotrexate here. I have the TNF inhibitors and some of these other DMARDs. I don't even touch that. That's above my pay grade. I usually send those patients right to rheumatology. And we're lucky enough to have some rheumatologists at Upstate who they actually invited me to do a talk much like this for their grand rounds recently. And they're very receptive to bringing these patients into their clinic. The last thing on there is synovectomy. That's another consideration for somebody who's got refractory joint pain. I've never done this up until about 2 or 3 weeks ago, where a patient who had persistent knee swelling and knee pain after clear-cut Lyme arthritis, basically his orthopedic surgeon was like, let's just go in there and we'll just clean it out. And he did a full synovectomy, and his joint pain went away within a couple weeks. His swelling was gone and he's doing great. So that's one thing to consider down the road if a lot of these other things don't seem to help. And would potentially increase their ability and their daily activities. All right, this is a convoluted slide talking about treatment with different DMARDs. Most of these patients essentially resolved at some point, whether it was due to synovectomy or the DMARDs themselves. So there's definitely controversy out there. If anybody's in the room, they've heard ILADs, they've heard IDSA. I don't think anybody's right. I think, what I like to try to do is try to follow the science to the best of my ability and not discount patients and their experiences. And I think that's probably the biggest thing to do is talk to the patients, see what they're going through, try to make sure that you and the patients keep their blinders off is what I usually say. Because a lot of my patients come in and are like, hey, I want Lyme treatment. I'm like, all right, well, let's take a step back. Let's look at everything, right? Because if we don't look at everything, you're going to go down a pathway of this Lyme disease path, which may not be the right path. Like my mantle cell lymphoma patient or my psoriatic arthritis patient, where nothing I was doing was helping. But then when we got them on the right therapies, they did improve. Some of the key guidelines from the IDSA that came out just recently, again, PCR testing is not recommended in CSF anymore. I've never really felt it was useful. There was some recommendation previously for Lyme arthritis that you could use oral antibiotics, and I've definitely seen providers use this as recently as 2 years ago. I've never really been a fan of it either. And most of the data seem to come from European data, which for whatever reason, their Borrelia species may be more amenable to oral doxycycline. I generally see people have treatment failure and then require IV ceftriaxone anyway. So I always tell people, treat with 3 weeks of IV ceftriaxone, you'll be better off. Again, we talked a little bit about the arthritis symptoms and the arthritis therapies from the standpoint of antibiotics, and then making sure you're considering the DMARDs at the end. All right, so that's a lot about Lyme disease, but what I'd like to also do is touch a little bit on some of the other co-infections that are out there that we're potentially going to get into, because between Dr. Beard and Dr. Saravanan, we've been scared to death to go outside. I think somebody mentioned to me earlier, it's just don't go outside. That's the key. So before I go on, any quick questions? Yes, sir. That's a good question. So the question is, if somebody has Bell's palsy, do you treat them as a Lyme meningitis, or do you treat them with, more oral antibiotics? I've seen people go both ways. I think if there's any meningitic symptoms whatsoever, I always just steer right into the IV ceftriaxone. I have definitely seen people who just have the Bell's palsy and maybe like an early erythema migrans rash presentation, and they can get away with the doxy. It's really kind of focused more on the meningitis symptoms for me. Banworth's, I've seen a handful, and I always treat with IV ceftriaxone. Yep. Yeah. So Banworth syndrome is like a peripheral neuropathy that people can get, generally in the upper extremities. So, yeah.
Do you ever treat with the combination of doxy and ceftriaxone together as opposed? I mean, there's some patients who like use everything. Well, I'm not going to get IV. IV drugs or IV antibiotics.
Yeah.
You do that? Yeah.
You mean IV ceftriaxone and doxy at the same time, or cefuroxime? Okay. I have. It's usually in people who, for whatever reason, I can't do IV ceftriaxone and I'm trying to maximize things. So I'll do doxycycline. I've also done high dose cefuroxime because the therapeutic window is pretty high. And so instead of doing 500 twice a day, I might do 1,000 twice a day. I've gotten creative. Some of the stuff I've done over the years has been borderline voodoo, to be honest. But, you get to the point where you got patients coming into your clinic and you're just like, I don't want people to suffer. I just want you to feel better. And you try things, and most of that stuff doesn't seem to work in my experience, but I've done it. All right. Yes.
Wait for the serological test. When you see the erythematous migraine, you do the test, or you see the tick bite, you do the test. What is the positive? Yeah.
So if I have somebody that comes in with a tick bite, and I think Wes is going to talk about this a little bit tomorrow, but I will give them 200 milligrams of doxycycline if it's been engorged and it's been on for at least 18 to 24 hours. It might go a little bit more conservative than the CDC maybe. I recommend the 200 milligrams of doxy, with the caveat that if they develop a rash or if they develop symptoms, then they need to come back right away. All right. I think too many times patients are told, oh, this is going to prevent you from getting Lyme, and they kind of go off, and 3 months later they've got knee pain or joint pain because it's not 100% preventive. All right. That's, I think, the big takeaway. If somebody comes in with erythema migrans, I treat. They get doxycycline right off the bat. Whether or not I'll do some serologic testing, I guess it depends on my mood a little bit. If somebody does come in with erythema migrans, you can maybe get a baseline modified 2-tier test, and then you can actually track that over time, so that if somebody does have persistent symptoms down the road, 6 months down the road, and you're like, well, let's just double check and see what your titers look like. If your titers are negative at that point, it's unlikely that you have an active infection still causing this, and maybe you want to try to focus on either alternative diagnoses or think about some of those inflammatory responses.
You mentioned there's some problems with the Zeus test when you get it outside the university labs. Is the problem with the storage, with the drawing? What are the? It's
just that it's a send out. It'd be really nice just to have it done inside the university, so I get a turnaround time within 2 days. Instead, especially with the COVID and supply chain issues, you're shipping it out, you're waiting for it to come back. There were some reagent issues. So it was anywhere between a 10 and 28-day turnaround time for some cases. So, yes, sir.
Does the Zeus test give you a numeric value, or is it just positive, negative?
Yeah.
Numeric.
Yeah. So the VLSE1 peptide C10 is a numeric value, much like the C6. And I've actually had patients who were had the C6 previously, and then I was like, all right, well, I got this new test. Let's see what that looks like. And it seemed to compare fairly reasonably. So I use it almost universally now.
What would you recommend in terms of what primary care physicians should be able to handle on their own, and when should they refer on? So if they have a patient with erythema migrans, should they do a primary course of oral and send the 2-tier test?
Yeah, I think that would be reasonable. I think making sure that we're not ignoring the rashes that are out there, making sure we're not misdiagnosing for cellulitis. That's probably the big thing. I think when people start having those persistent joint pains or the neurologic symptoms, that's when they should probably be referred on. Again, I think the neurologic symptoms are a little bit more challenging for me, at least. But the joint pains, I think we have some other options, and we could potentially do other therapeutics from an antibiotic standpoint as well.
Yeah. What is the wait time to get in to somebody like yourself? Because, you're asking, should we do it? And I've been doing this for 34 years. I've only had a half a dozen patients see the infectious disease docs, because it takes 6, 12 weeks, 6 months sometimes.
Yeah, it's not good, unfortunately. And I think Anne's in the back shaking her head up and down. The key is, I need to find a better way to get my schedulers to not be afraid of me, I think, because they won't reach out to me and say, hey, can you get this patient in sooner? Whereas like I have flexibility in my schedule because I do a lot of research stuff in the morning, and then I have my afternoons generally free. So I can usually get people in within a week as long as I'm not on clinical service, but it's sometimes it's those gatekeepers in our clinic.
And as a family doc, I use a lot of the Upstate specialists. I text them if I need somebody to see me. They call me back. Yeah. I tell them the issue. Are you willing to give your cell phone?
Oh yeah.
But if I have somebody who I'm really concerned about, and I don't want it to be 3 months because your secretary said,
yeah, I think I'm booking out till March at the moment, according to them. But yeah, I think that's fine. I have no problem. I give my cell phone out all the time. So anybody have a pen and paper? Yeah. So if you want my contact information afterwards, I'm free. Well, feel free to give it to you guys. All right. Yes, sir.
Let me get a Zeus test done. I've never seen that.
So
option.
it's gonna be a send out test that you're gonna have to do through whatever your lab is. It is an FDA approved test, right? So your lab should be able to figure out how to get it there. It's just that they need to know. All right, so it's the Zeus modified 2-tier test for Lyme. It's going to go to the lab. ARUP is what we generally see sent. At least that's what LabCorp contracts with. And you just need to have that conversation, and you need to make it very clear. I do not want the standard 2-tier test. I do not want a PCR. I want this test, because if you don't do that, you're going to get, it's like garbage in, garbage out kind of situation.
I've done this over the years. I don't know if there's any benefit at all. doing multiple Western blots and seeing if there's different bands and looking at the titer and see if it's up or down.
used to do that. I used to do that. And unfortunately, the Western blots just never seem to correlate very well. Like I'll have some people like, they'll come in and I'm like, I feel great, doc. I'm like, oh, you still have 9 bands positive. It's like, all right, what do I do with that information? So now that I've been using the C6 and then the Zeus test, it's been a lot easier. And it's somewhat more reassuring, I think, from the patients, because they'll say, I feel good, doc, but what do my assays show? And I'll show that things are trending down, and they've been trending down for months. It's something that it's another tool that helps. So, all right, I'm going to jump into the rest of it and we'll have time at the end. So I'm going to go through a couple of the other big co-infections, at least in the central New York area, based on, a lot of what Sarah Vonnen has done. And I got to thank Sarah Vonnen. His epi data has, basically predicted the anaplasma surge that I've seen over the past couple of years, 2 years ago, because he was telling me, wow, there's a lot more anaplasma cases in central New York, at least ticks that are coming in. And then over the past 2 years, it's gotten so common that I've actually diagnosed anaplasma on the phone with somebody. And, it's just becoming something that we see almost every summer. So, so before we get into that, we're going to talk a little bit about Borrelia miyamotoi. We've seen a handful of cases with this. This is another deer tick infection. This is not really related to Lyme. It's more of a relapsing fever spirochete. It presents much like Lyme, but a little bit more intense. I feel like a lot of the patients I've seen have had very high fevers, very bad headaches, general aches and pains, very much like anaplasma. So if you have somebody you're thinking might be anaplasmosis, you might want to throw a Borrelia miyamotoi PCR on there as well when they're presenting acutely. This is treated much like Lyme disease. It's usually several weeks of doxycycline. You can have a Yerix-Herxheimer reaction with this, and it's probably going to be more intense than Lyme. The other thing that I noticed is that if you have somebody who has a standard Lyme test that's positive, screening test is positive, but their immunoblock keeps coming back negative, even though you're like, they got a tick bite, and I know they were exposed to something and they responded to doxy. If they have a 41 kilodalton band that's positive, and that's all it is, that seemed to correlate with some of my Borrelia miyamotoi cases. You can do PCR in the acute phase. I've done serologic testing for people who kind of come in after the fact, but these are potentially pretty nasty infections that can also recur even after they've recovered from their initial symptoms. The other thing that, I think Brian Ledette, who's going to talk after me, and Sarah Vonnen have talked about in the past, is this is a nasty bug because it has the potential for transovarial transmission. So Lyme disease, if you have an infected female that lays eggs, those eggs are not going to be infected with Lyme, right? Those larvae that hatch have to bite an infected mammal and then pick up the infection. Whereas Borrelia miyamotoi, you can have this transovarial infection where the female will lay eggs, and those eggs, 2,000 to 3,000 or however many there are, those are all potentially going to be infected larvae that are going to then carry through the life cycle. So this is potentially something that we could see a surge of cases over the next several years. So is anybody sworn off hiking at any point? So, all right. Yeah, and fevers, headaches, really kind of prominent. A lot of muscle aches and joint aches, and the fatigue is pretty profound. I've had a lot of patients have kind of these symptoms persist even afterwards, and they've had to have a couple additional rounds of antibiotics. I'm not sure if it was the antibiotics that helped them or if it was just a tincture of time, but many of them did have some improvement. And then I talked a little bit about the C6 and the cross-reactivity with this. So I'm not sure if the Zeus test will have the same. So anaplasma has probably been the biggest thing that I've seen over the past 2 years that's really concerning to me, because these patients come in very sick. Usually they get a tick bite, and within about 5 to 14 days, they're having symptoms, and they're going to have a general TB or tick-borne illness where they're going to feel like they have flu-like illness, muscle aches, headaches, just not feeling well, high fevers. So I tell people, especially our medical students and our residents, if you have somebody in the summertime who has a summer flu, you need to think about this, all right? The classic scenario is bad headache, high fever, and then when you do your labs, you're going to see low white cells. You're going to see your platelets are going to be less than 100 typically, and you're also going to see a mild transaminitis, anywhere between 100 and 300. If you have that, that is a doxycycline deficiency, and they need to be started on it right away. And the key thing is too, when you treat these patients, they get better fast. I had this one gentleman at Krause who, he's in his 60s. He had some comorbidities. He looked very sick. Like I went and I talked to the hospitalist. I'm like, you need to put him on Doxy right now. But I would talk to the ICU because I think he's going that route. So they started him on doxycycline. I come in the next morning after his 2 doses of Doxy, and he's like, when can I go home and mow my lawn? He looked 100% better. Every single case of Doxy that I've seen that gets the medication early in the course generally has that kind of approach. If you let this go though, and they don't have any Doxy for 4, 5, 6 days, these patients can die. And every so often we have cases in the Binghamton area or surrounding areas where these patients don't make it. Again, you treat it with Doxy, you could probably get away with 5 to 7 days of therapy. The reality is you want to probably push the duration and try to treat it for at least 14 days, just in the possibility that there could be a co-infection with Lyme disease. And I would do the same thing with Ehrlichia. If you were to get a blood smear, you could potentially see the moruli, which, let's see where my mouse is on here. I can't see it. All right. Right there. So if you have a blood smear, you could potentially see this, and the pathologist should be able to pick up on that. The other thing that's also interesting with anaplasma, and I think most, if not all of my patients who have come in with anaplasmosis have had some kind of GI upset. That's just been my experience. Here it says 20%. Most everybody has anorexia. They have upset stomach of some sort. Some people have some diarrhea. Some people have some nausea and vomiting. But if you have that kind of summer flu, those lab abnormalities and GI upset, and you're in the central New York area, anaplasma is a good bet. The diagnosis I mentioned, low platelets, low white cells, the moruli. Serologic testing and PCR. So if you're early in the acute phase, they're just coming into the hospital, they were bit by a tick 7 days ago, the PCR is going to be the best bet, right? The reality is, sometimes you're just going to miss the PCR. If you get the PCR after they started Doxy, you might not be able to make the diagnosis. So I usually get acute serology. So I get the antibody test and the PCR when they're hospitalized. And then if the PCR comes back negative, then I can sit back and, have them come back in 4 to 6 weeks, get that convalescent titer and see that antibody shoot way up. I mentioned the duration. There is not typically a relapse phase in either anaplasma or ehrlichiosis. So a lot of patients will come in and see me and they'll say, I got multiple co-infections, one of which is anaplasma. I'm like, well, the good news is you don't have anaplasma anymore. The only documented Ehrlichia relapse I've ever seen is in somebody who had severe leukemia. I think they had AML and they were on chemotherapy, and they did seem to relapse and had to have another course of doxycycline down the road. But this is not a long-term thing. This is an acute phase infection that is easily treated if promptly done so. All right. And then the other big one, and this is something that was a little bit more prevalent this past year. I actually had 2 cases of babesia at Upstate in 1 week. This is a blood parasite, so you cannot use doxycycline for this. This is something that looks like malaria under the microscope. Interestingly, with one of our 2 patients that came in this summer, she was a Peace Corps volunteer and volunteered and spent about 20 years in Africa. And then she came back, and then she just had come back from Africa several months ago. And then she comes in with high fevers, low platelets, low hemoglobin, and she had a blood smear that looked very much like this. But she also was doing a lot of hiking, and she had known tick bites. So we eventually were able to diagnose her as having babesiosis, and she had about 4% parasitemia, which is actually quite high, and she was actually not doing very well initially, but she definitely recovered once we got her on the right meds. Somebody had asked about subacute illness. I have seen that before. Oftentimes it's somebody who's either got serologic positivity or maybe PCR positivity that kind of persists even though they're not really having any symptoms. A lot of times I'll monitor it and just kind of watch it, and I've seen it kind of go away on its own. Other times, if somebody's at high risk, if they're older, they have immunocompromised state, I'll give them some therapy for it if that's necessary. Yeah. I've done the same thing. It just depends on the patient. Everybody's different. This is something you can treat for 7 to 10 days, and you can generally clear the infection pretty easily. You want to either look for the parasite in the blood smear, do a blood PCR, which you can send off to Wadsworth at the state lab, or you can do the antibodies, the serologic testing via the IFA. It's supportive, but it's not confirmatory, right? I've had some people where they've had some elevated IgM, Babesia serologies, but when you do the blood smear, you do the PCR, there's clearly no evidence of it. I do mention 7 to 10 days down below. That's kind of the standard. There is a potential where you might want to use a longer course if somebody is immunocompromised. And that's actually part of the new Babesia guidelines when they split off from Lyme disease. So again, serology is not really the best option for diagnosis. You want that blood smear or the PCR. Most everybody that's going to get treatment for Babesia, you want to do the AAA or the AA therapy. So azithro and atovaquone. Quinine is the alternative. You know, that's something you could use for maybe severe disease. In the past, I think we actually use azithro for everything across the board now. And it's a question of whether or not you'll be able to find the quinine in the first place. The key thing here is if you have somebody who's immunocompromised in some way, you want to consider potentially getting them into CID urgently. They may want to treat for up to 6 weeks. We actually will monitor blood smears persistently and make sure that they clear. And we've had a couple of cases where they were really severe and required exchange transfusion. There are alternatives. These are all kind of expert opinion type stuff. We had a patient, one of the two that I mentioned had an elevated QTC on their EKG. So we really didn't want to put them on azithro and atovaquone. So we ended up using, I think, a combination of doxy, Clinda, and atovaquone instead of the azithromycin because their QTC was like 530 or something. One thing that you want to think about in your hematology patients is we don't screen for this for blood transfusions. And this is something that you can get from a blood transfusion. And if you get it, it's got a very high mortality rate. So if you have somebody who's got an unknown fever and they're on an oncology ward or it's one of your primary care patients, and you know that they've been getting transfusions through hematology, it may be something to think about. The other one, the other group that you really worry about is asplenic patients. We actually had a patient die about 2 or 3 years before I joined Upstate, who came in just septic, high parasitemia with Babesia. And this slide just basically says you can consider using the serology testing. Most people are going to have some kind of a serologic response, even early in the case, but it's not, again, not diagnostic. So that was like a giant kind of flood of information that I just threw at you guys. And I didn't even touch base on things like powassan and some of these other viral pathogens that are coming out, partially because there's not a lot to say from a treatment standpoint. But I want to open the floor up for any questions. Yeah.
Do you ever follow other inflammatory markers like SED rate or CRP?
I do. And I generally will only do that in somebody who's got Lyme arthritis, because if anybody is going to have the inflammatory markers be elevated, it's going to be those patients. It's interesting though, probably maybe 15% of my patients with Lyme arthritis will actually have a significant elevation in their SED rate or CRP. Most of the patients, for whatever reason, they don't. And I think it has to do with how much actual inflammation there is. Like if you have joint swelling, you're going to have an elevated SED rate. But if you don't have swelling, it's more arthralgias, it's not as useful. But I generally will order it, especially if somebody's on IV therapy.
Hi. So if you have a patient who has a positive result from Dr. Thangamani's lab, but who's totally asymptomatic, have you come across patients like that?
I have. So yeah, so the and this is for other commercial labs that are out there that do what Dr. Thangamani is doing. The IDSA guidelines actually don't recommend tick testing, which I don't believe in because we have Dr. Thangamani's lab. And I think part of the reason they say not to do that is because it does create some confusion, but they also cost a lot of money and there's no validation behind it. I think Dr. Thangamani provides a lot of good information from an epidemiologic standpoint. So I sent all my patients and their ticks to him. But that does create a problem, right? So you have somebody who has this positive test. What do you do with it? I think that the question is, all right, how long was the tick attached for? Is it engorged? Have you had any symptoms at all? When was it? It might be somebody where I'll monitor them over the course of a couple of weeks, or if there's a concern in some way, then I'll treat them. It's again, sometimes I chicken out. So.
Other questions, please, for Dr. Paolino? Anybody would like to? Yeah, up front.
This is good to know this patient that kind of sticks out in my mind. When you're talking about blinders, and I try to, I take every patient as like their own person, their own, go through their own experiences. But I really struggle with the patients with these really fierce blinders on. And the patient I'm talking about actually had metastatic breast cancer, and we had evidence of something more going on. And she kept saying, no, it's Lyme disease. No, it's Lyme disease. Like, how do you have like advice for us? Because I don't want to minimize their symptoms. I don't want them to feel like I'm not listening to them. But sometimes when I'm saying, hey, there's something more going on here, or for this patient, I mean, we had documented like radiologic evidence, as you know, of something more going on.
Clearly, I don't have great advice because it didn't work
Well,
for this patient.
This patient also was very unique. I don't think all are quite this extreme.
This was, yeah. So this patient, Kate referred to me, and yeah, she had kind of chronic back pain, and she just had like a variety of symptoms. And so what I do in those situations is I talk to the patient. I make sure I understand all the symptoms. And then what I'll do is I'll do that Lyme test. And I think her test came back, essentially negative. It was like 1.14, and 1.1 is like the upper limits of normal where it's positive. I think I even gave her some treatment with the caveat that she needs to follow up with her oncologist because she had lesions on her spine. And she absolutely refused to acknowledge that her metastatic breast cancer could have come back. And unfortunately, this is something where she had her blinders on. She wouldn't take them off. You can only do what you can do. You try to tell them, try to show them the evidence. You try to explain them what's going on. Unfortunately, that wasn't something that she wanted to hear. So these are probably the hardest patients.
Back here first. Okay, Rael.
Okay. So on the other end of the spectrum, we've talked a lot about patients with rashes. We know there's a significant population of patients who do not present a rash or don't see the rash if it's in an area they can't see it. So is there an intake checklist or a series of questions that a GP would ask to be able to do a differential clinical diagnosis based on exposure? Obviously, clearly we can check off the endemic area, but outside exposure activities and symptomology that would lead the doctor to make a clinical diagnosis?
I think that's a good question.
And
so
part B is, if there isn't one, could you create one?
Right. So you bring up a good point, because there are many Lyme clinics out there that use different tests and questionnaires. I've not seen that they've been validated in any way. And the questionnaires are very broad, where anybody that had rheumatoid arthritis could potentially trigger a positive Lyme test. It'd be nice to do a validation study of something like that. I don't know if anybody's worked on that. Brian, do you guys do anything like that in Columbia?
We have the GSQ, which it doesn't give a diagnosis, but
it kind of
track the course of symptoms.
Yeah. So I think it's just making sure that you talk with your provider. You make sure you make it very clear that there are tick exposures, whether or not there's a known tick bite. Like my niece, she had no known tick bite because it was a nymph in the spring, and she clearly had Lyme arthritis that fall. I think it's just something where as providers, we need to do a better job listening overall. And I think the antibiotic stewardship that my cohort of physicians, infectious disease physicians, have kind of hammered into people's heads over the years, when it comes to doxycycline, I don't care if you're using doxycycline. If you think that somebody might have an exposure and they may have had a tick bite, use doxy. I've never gotten bent out of shape over tetracycline resistance. So that's probably what I would recommend is, if you're in doubt, use doxy in Central New York.
I'm sorry, Kathy Rosito has her hand up on the Zoom call. Kathy, you can unmute and ask your question.
Great, thank you. Thanks, Chris. Great presentation. So this is more of a policy question. I heard Dr. Augustine's question about primary care physicians having challenges getting to a specialist. I know how many cases we all refer to you. Is there some intermediary step we can put in place consults for primary care physicians, some kind of special in-between step between them and you that would give them more support in the field. Thoughts?
Anybody have an answer?
No.
I think things like today, like the summit that we're doing with you guys and everybody that's come out and taken your time, trying to get some education so we're all kind of right sized and we're all kind of coming from the same place. I think that helps. I don't know how else to do it, other than just continue to try to educate not just the providers, but also the public as well. I still have people that live in my town who are like, what does a tick look like? I'm like, you're 50 years old. You've lived in central New York your entire life. How do you not know what a tick looks like? So.
Right there.
Thank you.
That you send your ticks and all your patients' ticks into the clinic. And I understand the role for research, but in a realistic sense, are you using it for clinical diagnostic purposes at all? You're basing that on the symptoms, the exposure, and the labs.
Yeah,
right?
yeah. If somebody comes in, they've had a tick bite, I'm gonna treat them with Doxy. If they have a rash, if there's a tick bite and I want to use the preventive Doxy, I'll start with that, and then we'll have that information in another couple of days. Back when it was taking Saravana's group 10 to 14 days to get things turned around because of funding, it was a lot more difficult. Now, like, people will say, hey, I had a tick bite a few days ago and Dr. Saravana tested it, and I have more of an answer up front. So it helps a little bit. I think the key is if I put somebody on Doxy and then they come back and it's Lyme and Babesia or babesiosis, then it becomes a little bit more concerning. I'm like, all right, do I want to treat them for Babesia now and just kind of be done with it? Or do I want to kind of monitor and see how they're doing? Some people, surprisingly, some people are like, I don't do well with antibiotics. I like to just kind of wait and see. And I just have sequential follow-up, right? Have them come back in 2 weeks, have them come back 2 weeks after that. I even do telephone calls or telemedicine. That's been a huge benefit, I guess, to COVID, is being able to do that and having more of an outreach to some of my patients that live an hour and a half, 2 hours away. So. So if it's like Babesia, I might do a blood smear or a blood PCR or something like that. I wouldn't necessarily do the serology that frequently, but.
Well, one more question here.
Just a question on the testing for the C peptide and the zoosis. If the insurance don't cover it, how do you advise patients how much they have to pay out of pocket? Do you get a complaint?
I've actually not run into that.
So do they cover?
Yeah, so it's an FDA approved test. I haven't had any patients tell me that their insurance didn't pay for it unless they had really limited insurance and they could only go to like one specific lab, or, for example, like our Krause colleagues that work at Krause Hospital, they get all their care through Krause, but I can't routinely get my testing done through Krause easily. So they end up having to pay out of pocket, but I haven't run into that, too much at all. At least not that people are telling me.
I don't want to forestall any questions, but I do want to make sure we preserve as much of the break